recording? Great. Well, this module, let me just review the study outcomes because we're introducing a new outcome measure to the burn community called PODS, or PODS plus death. It's a composite. And so typically we don't like composites. They add things up, and there's problems in the literature with composites. But I want to go through a little presentation explaining to you what we've done, how we validated in burns, and now it's our primary outcome for the pivotal trial. So here we're talking about a composite of being alive and free from organ failure as defined by the need for life-sustaining treatments at that time point. It could be 14 days, could be 28 days, could be 90 days or whatever. For this purposes of this trial, we've chosen 28 days. We're going to say, are you alive? Typically, 28-day mortality would be a primary outcome for an ICU trial. But if you're alive and on mechanical ventilation, or on mechanical ventilation receiving renal replacement therapy, or on mechanical ventilation still in shock, receiving some form of circulatory support, should that count as a success or as a win on the win side when you're judging the efficacy of therapy at day 28? We argue no, that if you're alive and needing these life-sustaining therapies, that's still a problem, and we're counting it on the failure side and judging it in that way. So we're combining death with being alive and receiving these life-sustaining treatments. And in the early data set from Reenergize, we validated this point, and I'm showing you here that the mortality rate at 28-day in a subset of the Reenergize patients was only 6%, but there's still another 18% of patients that are on mechanical ventilation, on dialysis, or in shock. So when you combine those, you get a higher event rate, and that affords us some statistical efficiencies that I'll show you in a minute. But to validate this concept, we said that, well, at day 28, if I don't have PODS, we showed that the survival at 6 months is pretty good. But at day 28, if you still have PODS, you have a much worse 6-month survival. So it is clinically important to have PODS at day 28 because you have a greater survival and your 6-month quality of life is a lot lower, is a lot worse than if you don't have PODS. And so these observations of at day 28, people do a lot worse 6 months later, support the clinical importance of this and enable us to combine the presence of PODS with death, which, as I said, gives us statistical efficiencies. And here I'm just trying to illustrate sample size requirements. If I just looked at mortality alone versus if I combine them in a binary way, combine event rates with death and the presence of PODS, or in the bottom in a continuous measure, PODS-free days, over 28 days, you see the sample size requirements are a lot less. So that's why with VICTory, our sample size requirements are lower than they are than with Reenergize, where we only need 666 patients to accomplish an adequate power using this combined PODS plus death. I'll also remind you that when we talked about the Lovett trial, proof of point, unfortunately in the wrong direction, that individually mortality or individually each of the components of PODS was not statistically significant, but the primary outcome did gain positivity because of combining those event rates and increasing the statistical precision. So there are still statistical efficiencies, and it's clinically relevant to giving vitamin C, hoping to protect organs and save lives. We combine those events rates together, we have more power, we need less patients. 666 being our overall goal. These secondary outcomes are very similar to what we're doing with Reenergize. I highlight in red time to discharge alive because that is our key secondary endpoint, if you will, which was the primary endpoint for Reenergize, but it would require a larger number of patients. And so we switched to PODS plus death. We're collecting routine labs. These are not things that we're making you do, but if you do them, We're capturing them in the data set. We're interested in organ failure, particularly the kidney. And so as part of PODS, we capture renal replacement therapy whenever it's used during the hospital course. But obviously, if you're daily measuring urea and creatinine, we're going to capture that in our data set. We'll be able to speak to kidney injury as an outcome. Similarly, if hemoglobins or haptoglobins are being assessed because of hemolysis, we'll capture that, in our routine labs. And then just to let you know, you may not be participating in the lab study, but there are some, particularly in Germany, units that are doing a funded laboratory sub-study where we'll be measuring vitamin C levels, markers of oxidative stress and antioxidant capacity, markers of inflammation, and markers of acute kidney injury. And that'll be important in the story that we try and tell about the safety and efficacy of vitamin C in this setting. As I mentioned in an earlier module, we also are capturing these events of interest: the new diagnosis of oxalate kidney stones, severe hemolysis, acid-base electrolyte abnormalities, and refractory hypoglycemia. So exactly how we capture that data and where in the in the REDCap, I'll save for Maureen to explain to the research coordinators. At this level, I just wanted the physician investigators to be aware of our approach to capturing the outcomes for this trial. Any questions? And Maureen.